Hello everybody, my name is Annette Thomas and I'm co-chairing this session with Susan Myles. So the session is the Developing Technology and Innovation for AHPs and Health Scientists. So just telling you a little bit about myself, and I'm just going to put it into full screen there so you can all see screen. I'm the National Clinical Lead for Point of Care Testing in Wales. I'm a consultant clinical biochemist by background. I'm also Director of WEQAS, and what I'm going to talk to you today is probably a combination of those two roles. So what we're going to do is we're going to start the session where I'm going to just give you an overview of some of the technology and some of the innovation that's come our way more recently. And then Susan, who's the Director of Health Technology Wales, is then going to give you an overview of some of the work that they've been doing, and then we're going to have an open session, and I hope you've got loads and loads and loads of questions for us. As far as the questions are concerned, you can either put them in the Q&A section or you can actually raise your hands, okay? So if you're all ready, we can start the session on developing technology. Except it is not moving. Okay, that's a good start. Sorry, it is not moving. It should have moved. Yes, please, Rachel. Rachel is going to share instead. We've got a technology problem, so that's a good start. So it looks as if we've got 15 people in the session, which is really good. So we've got a nice small group, so we can have a more interactive session. Okay, so what I want to do is just throw at you a few of the some statistics as far as where we're at now and where we were a year or so ago. And I know some of these things actually came up in the talk earlier this morning about the digital healthcare. Well, we have hit quite a digital revolution, and most of these slides are from Ofcom studies that were published fairly recently, but we have actually entered now a post-pandemic digital revolution. So if you look at the amount of adults that are now looking at apps, actively using apps on their smartphones and tablets in the UK, it is actually quite outstanding. There's 42.5 million adults. A lot of it as a result of the pandemic, as you can see. So those graphs there actually show you the different timelines and years. But essentially the pandemic pushed people in the UK to use video calling services as well, to keep in touch with family and friends. So we have had a huge burst of the digital revolution as far as using text online. The actual NHS sites and apps which were launched last year had 22.5 million adults downloading it in March 22 during the spring lockdown, and actually that's continued to rise as in the data that's come off for 2021. So you can see the blue line there is the 2021 data, and it's still going up. So you can see that we have entered quite a revolution as far as the number of people that are now using apps on their smartphones in the UK. Can you, next slide please, if I can process it. And I think it's going to not halt, I think it's going to get bigger and bigger and bigger, because if you look at the big five, Google, Apple, Facebook, Amazon and Microsoft, they've now developed a plethora of apps, and very, very specifically in the UK health and wellbeing sector. So Microsoft have got cloud-based artificial intelligence and machine learning to existing healthcare companies. They've done a deal fairly recently with Nuance, which enables clinical intelligence using a voice-enabled solution of AI. And looks as if my screen has just gone off completely. And that's to monitor the doctor-patient conversation and suggesting what actions need to be undertaken during this virtual consultation. Apple and Google have also really taken off as far as wearable products, and I'm sure most of you here have used some of the wearable products at some point over the last 18 months or a few years. And there are a wide range of COVID-19 apps, including health trackers, now available as well. Amazon have got their pill back, which is a full service online pharmacy. And also there's this Halo fitness tracker, which listens to the user's voice to gauge their mood and scans their body to measure body fats. On the right-hand side there, I've got on the screen, you probably can't see it very, very well. You need to home in on the screen, but it's basically Microsoft Cloud for Healthcare remote patient monitoring, which is actually not just looking at sort of video conferencing or anything with the patient, but just actually picking up some of the vitals as well. So there is a huge amount being done, and now that the 5 biggies are involved, I think the genie's out of the bottle, and we're actually going to get more and more apps coming our way, and very much focused on healthcare. Next slide, please. And there are huge drivers both in the UK and in Wales specifically. And if you look at although one of the speakers this morning said that our informed health and care, the digital strategy, a lot of what is in there is still valid, sort of improving access to information and introducing new ways of delivering care with digital technologies must be at the heart of our service and our vision for prudent healthcare, and that was by Mark Drakeford in 2015. And more recently, obviously, what we're all quite familiar with, which is the healthcare science strategies, innovation and technology progress sits at the core of the healthcare science disciplines. Society is riding high on the wave of fourth industrial revolution that is driven by data and rapid technology advancement, and that was for Gethin in 2018. But I think it's moved at a pace since COVID, and I've just got a couple of examples there with Tech Cymru and some of the video conferencing facilities that have been enabled over the last 18 months, and some of the apps that have also been enabled through Digital Health Wales as well, to improve the way that we actually deliver healthcare as well. So it's essentially the message is that we all start routinely using digital apps, wearable devices and other online resources to be well-informed and active participants in the care of our patients. Next slide, please. And this is sort of where some of the diagnostics anywhere approach comes from. So Google some time ago did actually develop a smart contact lens. The smart contact lens had essentially was a glucose meter, and it had a glucose sensor. It didn't take off as well as they thought it would take off, essentially because the technology at that time, when it's probably about 3 or 4 years old, it was painful. Some of the electrodes were painful on the eye. However, as of this year, there's a new Korean device on the market, which is a much softer design. It doesn't damage the eye, it doesn't hurt, and it is something that, you know, these are from wearing things on our wrists and wearing things from on our legs or whatever it is. We are now going to be starting to look at some of these diagnostic anywhere devices in our eyes as well. And obviously we had some really, really good examples of some devices with one of the sessions earlier on with the Cochlear remote app as well. Some of the things that have been around for a while and have got some good evidence base behind them are the continuous glucose monitoring on its own, and also integrated continuous glucose monitoring, and the flash glucose meter, And we've got quite a bit of evidence behind some of the uses of these devices now. And obviously I illustrated there some of the nice guidelines, the nice diagnostic guidelines as well. And also the HGW evidence appraisal review of the flash glucose meter. Good evidence for using those. So there are other devices that have come on the market, which are portable ECG monitors. I'm just picking a few things here because there is a plethora of different devices on there, just to give you an idea of what is good and maybe what is not so good. So there are some good portable ECG monitors, there is not so good portable ECG monitors, and a recent review undertaken by NICE, which is Diagnostic Guidance 35, which was done in 2019, basically recommended that further research is needed, whilst some of the other ones there that I've identified for glucose, continuous glucose monitoring, the recommendation is to use them in certain situations, whilst for portable ECG monitoring, maybe it's not quite there yet. Next slide, please. So what has happened more recently is there's been a huge impact of COVID on innovation and transformation. And certainly over the last 18 months or so, there have been an enormous number of new technologies based on a biosensor technology advancement because of COVID. And if you just Google sort of biosensor technology, there have been an enormous number of applications using very, very new technology for infectious diseases. That includes sort of smartphone point-of-care diagnostics. There's some film technology, which is what that one is there. That one. The Stanford University, they developed some very, very thin films for the detection of HIV, various bacteria, CD4 and T lymphocytes. And the one on the left-hand side there is a SARS-CoV antigen test using thin film technology as well. Also on innovation and transformation, we had the published document on COVID-19 Innovation and Transformation Study Report, which showed that because of the pandemic, there was more agile use of resource, staff well-being, working together, accelerated decision-making, sustaining the pace of innovation and change, and we all did that pretty well. Digital access and confidence, we were actually starting to use things differently, using digital technology in a different way to help us deliver the services, and also embracing new technology. And I think that was one of the big changes. We had to embrace this new technology to be able to cope with the pandemic. But next slide, please. But one of the things that, so it was both an enabler, and also there was the plethora of devices and the plethora of different technologies that came out. It was an enabler and a barrier. And certainly in the first 6 months or so, I spent, as the National Point of Care Clinical Lead for Wales, I spent most of my time trying to go through all the bombardment of information I had from the different companies to say, you know, this is a new technology, it can do this, it can do that, it's going to revolutionize what you want to do. Really trying to go through what was good and what was bad and what we shouldn't actually touch at all. So there was too much being bombarded at us at the start, and we had to sift through it all to come up with what was good and what was not so good. So the technology that really has advanced because of COVID, especially on the area that I'm more interested in, which is point of care technology, is obviously we've got we all know what lateral flow tests are now. I don't think there's anybody in the UK or even worldwide who doesn't know what lateral flow technology is. However, it is actually, I'm not bundling that with new technology. It's actually very, very old technology, but with a new application, because it's been around for a very, very long time for all sorts of other tests, including pregnancy tests, for instance. So it's old technology, but bringing it in with the new application. And then some of the newer ones, then we've had molecular technologies. Isothermal techniques has been around for a long time, but not in a sort of a miniaturized form that we can use them in a point of care environment. So there are a few that came out during the pandemic, and some of these are actually already being used in Wales. The ID now is being used, the Roche Cobus Liat is being used, and also some of the other ones, the other one I'm going to mention in a minute, which is slightly different technology. So those PCR and isothermal techniques are actually similar to the laboratory techniques, but actually miniaturized into devices that can be used very much in the front line. And then on the left-hand side, I've got, this is a totally new technology using this film technology, which is microfluidic immunofluorescence, and essentially a lab on a chip. It was really brought on board just prior to COVID hitting, but it hadn't really got a lot of impact in the UK market prior to COVID. But since then, it has certainly now had a huge impact. But as I said, one of the big things that that we had to consider, because there were hundreds and hundreds, you could even say thousands of different kits, methods that came on the market and literally flooded the market. And one of the questions that is very close to my heart, both as the National Clinical Lead and also the Director of WEQAS, is how to ensure that these are actually fit for purpose. So if you look at the next slide, please, and hopefully some of these questions I'm posing to you so I won't have the answers to everything. I've got more questions probably than answers. So one of the things that we did, we couldn't have done it on our own because obviously Wales is quite a small country. So we had a 4 nations approach to looking at all of the kits that were on the market that basically flooded our inbox. And you can see that so this was coordinated by the Department of Health and Social Care, but all of us were involved in 4 nations. But over the 140 different devices that they evaluated over that period, only 19 were actually approved. So if we'd gone ahead and taken on board what the manufacturers were saying, we would have probably made things worse and had to give them the wrong results to our patients. So it's very important that we actually make sure that not only when we get new technology and that the technology is robust and actually fit for purpose and does exactly what it's supposed to do. And then if you look at, so that was the actual more of the molecular testing for SARS-CoV-2. And then if you look at the evaluation of the assays for the antigens, these are the lateral flow devices. Again, over 120 different manufacturers came forward and said they wanted to have their devices evaluated, and 42 of those were actually eventually passed through to phase 3A validation. So it was quite a long process, but we did validate a lot of devices in that period. Next slide, please. And one of the we had a session this morning again touching on research. I think this is an example of where we all really work together. We work together across Wales, all the NHS trusts, health boards rather, in Wales, plus Health and Care Research Wales, plus the UK government also, who are facilitating the Condor program as well, essentially got together, and we were trying to do a fast track of the evaluations of these devices, and Wales played a part. And one of the devices that we looked at was using the Lumina DX platform. This is the one which is the multiplex one, which is using this thin film technology. It didn't perform as well as some of the other PCR tests. However, this is an example of how we all got together across all the health boards in Wales to try and get as much evidence as we possibly could to look at whether this device was fit for purpose. And it was coordinated through a Falcon, which is a secondary care arm of Condor. And Condor is the COVID-19 National Diagnostic Research and Evaluation Platform. And that was funded by NIHR and UKRI as well. So a huge amount of work was done, and we really played our part. And between October and pretty much the end of November 2020, every ED department across Wales virtually, not quite, but nearly all of them took part in this study. Next slide, please. So what I'm saying is, it's not just the technology that we really need to think about, and the way in which we've had a plethora of new technology. We need to make sure that they're also fit for purpose. So a couple of questions I wanted to raise with you really is, so the challenge is, we're in the situation now, genie's out of the bottle, we've got a rapid advancement in biosensor technology, combined with the digital revolution because of the pandemic within healthcare. It is really driving the increase in development and use of wearables, point of care, as I've just given you some examples of as well. Also AI and ML, although I'm not going to touch on that today because actually that's probably a 40-minute talk on its own. So one of the questions and the challenges we have is, can we ensure that performance meets the clinical utility of the device, that the quality is appropriate and is safe to use? One of the suggestions, possibly solution, but again, I want you to think about this in our Q&A session, is, you know, what we do need to make sure that we've got evidence-based guidance there, that we've got feed in from HTW, from NICE, from local clinical evaluations, tied in with laboratory evaluations in some instances, looking at sort of when the device is then on the market, we do post-market vigilance of that device using external quality assessment data, which is the work that we do in looking at how the devices actually perform, how the methods perform once they're actually being used in routine practice. And I just got a few of our sort of logos there for you, just to make you aware of the type of organisations that really need to be involved to make sure that the evidence is there and we are actually using the devices appropriately. Next slide, please. And the other type of challenge, I think, and again, it was touched upon this morning, is that many new and emerging digital technologies rely, certainly the apps do, some of the work that the apps with the big five I indicated earlier, they rely on the ability to collect, store, access and share medical and other health related data. So that is quite important data. It's private, it's personal to the individual. So the challenge to us really is the quality of the data used to inform these tools, including the data gathered through continuous monitoring and tracking that may be intrusive in some area, in some examples, must be assured in order to facilitate their safe and effective use. We can't allow this data to go into inappropriate hands. We've got to make sure that we've got the right quality of the data. And obviously we've got information governance there with the through the NHS Wales Information Governance Policy and also the iOS as well. So again, the solution is to have the robust data governance processes in plan. Also, cybersecurity comes into this, and we just need to be mindful that just because the technology is there, it can be used, that we just need to protect that data that is being accessed, and know exactly where that data is going, and to make sure the quality of that data is robust. Next slide, please. I've got lots and lots of challenges, not many answers. And then the other one in relating to data governance as well is, again, this comes down to some genomic data, and I think this is of even more importance because of the challenges in data governance, and this is particularly complex due to the biological link with relatives. There was a public dialogue on genomic medicine, and it's called Time for a New Social Contract, and it's well worth a read for those of you that are interested in how we actually have a dialogue with the patients and what sort of things we need to ensure. There were very clear red lines on what was acceptable and what was not acceptable for the patients. Next slide, please. I don't have the answers to these questions. I've got lots of challenges, and hopefully we can discuss it at the next session. So the challenges, again, another one, and this is the Topple Report. And again, I think one of my colleagues this morning did mention the Topple Report. And basically, what it says is that within the next 20 years, 90% of all jobs in the NHS will require some element of digital skills. Staff will need to be able to navigate a data-rich healthcare environment. So the challenge to us is all staff will need digital and genomics literacy. Well, I think that 20-year gap has shortened because of what's happened in the last 18 months. You know, the telemedicine side of it, that has definitely shortened. The smart apps, it's definitely shortened. The wearables, that's shortened. So we're not looking at within 20 years anymore. And the Topple Report only came out in 2018, I think it was. It was not that long ago, and yet things have moved forward at a fantastic pace. So one of the things that it discusses is actually what we need to do is we need to start investing, and we need to investing early. By the time it really came out, we couldn't have predicted the pandemic, but really we have developed things incredibly quickly, but we need to have NHS organisations that can invest in their existing workforce to develop these specialist skills, including the assessment and commissioning of genomics and digital technologies. And that's one of the recommendations that they came out with. They need to identify future champions early and create networks to enable collaborative learning. And I think that's also been picked up this morning as well and discussed this morning. And I think that's part and bundle of some of the sort of healthcare science workforce going forward as well, that we really need to champion these individuals. And then we've got NHS board. NHS board should also take responsibility for effective knowledge management to support this innovation and change. So I think there's the Topple Report is worth a read. There's an awful lot of information in there, but the three key messages that I took out of that is they've got their timescales wrong in that we don't need 20 years. This is going to happen in the next 5 years. And certainly, you know, and the solutions, we need to invest now. Next slide, please. And then I think this is my last slide from memory. And again, this was also touched upon this morning, looking at research, and it was also in a session by my colleague John Geen earlier on this afternoon. There's been the recent studies, and there was a paper on transforming health through innovation, integrating the NHS and academia. It was published at the beginning of 2020, and basically saying we really need to engage with research. There has been a decline in the number of NHS staff that are now dedicated to engage with research. And obviously, the worrying thing is the situation is likely to worsen with our current pressures on the healthcare workforce. We all have difficulties in recruiting and retaining staff. but we really do need to try and ensure that we've got that we maintain the research and link it with and keep it within the NHS. So the challenge is there is an urgent need to enhance the NHS academia interface to better harness the research expertise and capability of the NHS for the health and well-being of the nation. It came out, this paper has come out with 6 themes, 6 solutions, and again, it's worth a really good read. Creating a healthcare system that truly values research, and John reiterated that, and this morning that was also reiterated. Fully integrating research teams across academia and the NHS, providing dedicated research time for research active NHS staff, and ensuring undergraduate curricula equip healthcare staff with skills to encourage research, and incorporating flexibility into postgrad training pathways. And also streamlining research through joint R&D offices. And I've got obviously the badge of Health and Care Research Wales there, because a lot of this they are actively actually trying to promote now, and to make sure that these solutions are brought forth, and also show that we can actually do things on a bigger level when we actually combine forces as well, through the example I gave from the Falcon study. So that's a very quick run through what's the digital technology and innovation that we've seen over the last couple of years, and the way in which it has really flourished over the last 18 months, and a lot of questions and challenges I hope we can add to the Q&A session. So now I'd like to pass you over to Susan Myles, who's the Director of Health Technology Wales, and hopefully she will be able to solve some of those issues that I've raised and ask some further challenges.
Thank you, Annette. I'm not sure if I'll be able to solve them, but I think you've set up the introduction to HCW quite well in terms of the offer that we can bring forward to solve some of those challenges. So as Annette said, I'm Director of Health Technology Wales. I'm a health economist by background, and I've been involved in health technology assessment in academic and care settings for around 30 years. And the brief I was given today was to think about how HCW can assist in helping to develop technology and innovation for AHPs and health scientists. So I plan to do that just by giving you a very quick introduction and overview of HCW's work, to provide some examples of how we'll support developing technologies and innovation, how we're doing that already, and to say a few words on the impact of our work and our strategic direction, but to finish off by considering the reciprocity and the relationship between HCW and the AHP and health science professional communities. And again, like Annette, concluding with some challenges and things that we might want to pick up within the discussion. I only plan to speak for 10-15 minutes or so, so hopefully that will give us some time for discussion. In preparation for today, I had a quick reread of some of the key strategy documents within the AHP and health science field, and it was reassuring to see that they're liberally sprinkled with references to value-based healthcare and the central role that innovation and technology can offer for care services within Wales. And this was very encouraging for me, because this is, I think, precisely the area where HCW has the most to offer in terms of delivering against those aspirations. So quick bit in HCW, we were established literally just 4 years ago. In 2 days' time is our 4th anniversary, and our remit was to provide a strategic, streamlined and nationally coordinated approach for the identification, the appraisal and the adoption of medical technologies across Wales. So our initial setup budget was £1 million, and we had a headcount of roughly 20 people. I'm delighted that that's been increased recently, and we're fervently recruiting new staff so that we can increase our outputs and support for care services in the foreseeable future. So turning first to our identification remit, HCW typically identifies most of its topics through regular topic calls. We accept topics at any time of the year, but we also run a couple of targeted comms campaigns to promote topics once or twice a year in addition to that. So traditionally these have been open topic calls, so effectively our definition of medical technologies is a very broad church, effectively anything that isn't a medicine, so we'll take any any medical technology that is sent to us and consider it. But for the first time in next year, we're going to be trialling some targeted topic calls, and in January 22 and June 22, we'll hold our first social care topic call and digital care topic call, and reflecting on some of the myriad digital technologies that Annette just referenced. I think that I'd really hope to see that we'll get some great topics coming forward for appraisal, and please do think about that, and if there are any that we can support you with, then we'd be delighted to have a discussion and to help as far as we can. So in the last 4 years, we've received over 300 topic referrals. Approximately a third of those topics are notified to us from industry, a third come from the NHS, and a third from a range of other sources. And we typically have received good referrals from all 7 of the territorial boards, as well as some of the specialist trusts, etc. But what I would say, though, is that we've actually received very few that have come direct from allied health professionals or from health scientists direct, although many of our guidance are relevant for those professional communities. And that's something that would be really great to talk about within our discussion. So how can we actually serve your community more directly and help you to appraise the technologies that you think will deliver the most value for those who use services within NHS Wales. We also engage in a number of discrete activities to support innovation. So we have a scientific advice service, or SAS, and we do that using the NICE Meta tool, where we work with innovators and technology developers, some from industry, some private individuals, some that are from care services, to try to understand what is their technology, what's its value proposition, what does it bring to potentially bring to care services, and where might their gaps be, and what evidence do we need to be able to consider those technologies going forward. We've also done a fair bit of work with the Bevan Commission, for example, supporting their Health Tech Exemplar programme. Recently, in the last year, 18 months, we've done a fair bit of work with the Small Business Research Initiative, looking at their calls, and particularly over the COVID pandemic period, we've been involved in several of them. And more recently, we're involved in 2 national programmes, one with NHSX. We've become a technology-specific evaluation team to look at AI technologies that are being brought forward by companies with innovative ideas, and that's in partnership with Tech Cymru and also Swansea University. And then another big new initiative that I think will be a GB-wide initiative that will be of interest to this audience is something called, it's a provisional title, but IDAP, so Innovative Devices Access Programme, and that's a programme that's being run in collaboration with NICE, MHRA and the Scottish Technologies Group, and it plans to go into the pre-market space and to look at the value propositions for technologies before they even have the regulatory approval, and to work with those developers to bring forward the right types of evidence, the aim being to encourage them to collect evidence that will expedite their adoption if in fact their evidence demonstrates that they deliver that promise. I don't have much time to go into the detail of any of these things today, so there's lots of information and case studies in our work with industry and our scientific advice service, and a video on it on our website, so please do take a look at your leisure if you've got some time. So turning now to our appraisal remit, so this is basically the guts of what HCW does. We aim to use the best available evidence and expertise to independently appraise technologies. We adopt a life cycle approach, and what does that mean? That means that we're interested in everything from innovation, so very early ideas, right through to obsolescence. So yes, disinvestment is within our scope. We rarely get topics for disinvestment, but if you have any that you think are candidates, then we'd be delighted to discuss those with you. We have a very collaborative process that involves extensive expert engagement, as well as an active patient and public involvement process. All of our meetings are held in public and bring forward patient and user submissions and testimony as evidence. So we try to be as transparent and rigorous as possible. And as I mentioned, our meetings are in public, so if you have time to perhaps come along and observe one, we'd warmly welcome you, and hopefully that would give you a good understanding of our processes and how we work. And then ultimately, all of this work is moving towards the production of independent evidence synthesis, which outline the evidence to support a technology or otherwise, and then the production of national guidance for care services in Wales, which offers guidance on whether there's sufficient evidence to support routine or niched adoption for those technologies within Wales. So the key steps in the appraisal process, I'm just going to go through this super quick. You send us an inquiry. If it's in Remit, we produce something called a topic exploration report, and that's a day or two of researchers' time. And what we're trying to understand is what's the quality and the quantity of the evidence to support review of this particular technology. Those go to our assessment group, which is the workhorse that looks at the evidence synthesis for our reviews. And that group is also the same group that uses an agreed set of criteria to prioritise what makes our work programme. If it makes it onto the work programme, then we produce a very detailed evidence appraisal report within a rapid review framework. That usually happens within about 2 to 3 months. And then that evidence appraisal report, alongside expert in opinion and peer review comments, are passed to our appraisal panel. The appraisal panel is a national decision-making body that has representation from all the usual stakeholder groups you'd expect, all the boards, Social Care Wales, and the major peer groups, etc. And their key job is to produce the national guidance and to issue that to the service. And that is issued with the status of adopt or justify. So adopt or justify effectively means that the services, care services, are expected to take cognizance of the guidance that we offer. So this slide just shows just happens to be was our first piece of guidance on mechanical chest compression and out of hospital cardiac arrest, and this was referred to us by WAS, Welsh Ambulance Service. And so what it typically looks like is a frontline page which has got a blue box with the headline guidance within it, and then that's accompanied by some detail on the particular issues that were discussed within the appraisal panel's deliberations to inform the guidance, and always accompanied with the very detailed evidence synthesis report where you can go to get the actual the actual synthesis of the evidence and assessment of its quality, etc. So I think we're up to about 25 pieces of national guidance now, and these are just a selection that I picked out that seemed to me to have some relevance to AHP and health science communities. So mechanical chest compression I mentioned, Freestyle Libre, Annette has touched on already for community monitoring of diabetes. We've also been asked to look at novel tracers for PET-CT for prostate cancer, RAD-T testing for strep A infections for use within community pharmacy settings, CPET, cardiopulmonary exercise testing for prehabilitation prior to major abdominal surgery, point of care ultrasound for use in the community, and also our most recent piece of guidance was on our first social care topic, and it was a bit different, and it was looking at strategies for the intervention to improve mental health of carers of people with dementia. And interestingly, that one had very good high-level RCT quality evidence to support its adoption across NHS Wales. So in terms of the status, I think I mentioned we have adopt or justify status for our national guidance. We held a national task and finish group that helped us to design how that will work. That agreed that the All Wales medical directors would be the lead national peer group that would help to support this work. Each of the local health boards have nominated a lead committee that will liaise with HEW on our annual adoption. And in our remit, we have the remit to audit not just our own guidance uptake, but also the medical technologies guidance from NICE, which is also another set. We've just launched the pilot this week. We're doing a retrospective of 8 of the first pieces of HEW guidance that have had a few years to bed into the system, and we've deliberately picked them to represent a range of different types of medical technologies. So that's everything from devices to procedures to actual things that are within broader care pathways, to try to test that audit system and see how well it works. And we expect to prepare our first report back to Welsh Government by the end of the financial year, 1st of April next year. So the so what question in terms of HEW, so what's the potential impact of our guidance? So we've had a prospective impact evaluation strategy since HEW was introduced, and this has been really crucial to try to demonstrate what the value add of HEW's assessments are and the return on the investment. So our economists estimate that for the first 15 pieces of guidance, that those estimated had impact for 137,000 people, and that they saved nearly £6 million per annum year on year for care services. So as well as the obvious benefits that are derived in terms of the most important health and wellbeing outcomes, there are also potentially considerable system savings to be derived and identified by looking at the evidence in this way. So there's lots on our impact section on our webpage if you want to find out more about that. But I'm really pleased to see that we just were awarded a prestigious international prize, the INATA Impact Award, for HW's approach to their impact assessment, and for some of the case studies of the impact that we produced. And that was voted on by 50 of the 100 attendees at a conference that represented 50 of the international HT agencies across the world. So just thinking about what we're going to be doing next in terms of the future for HTW. So as I mentioned, we're really delighted that we've actually had a significant increase in our funding. We've become recently part of the Welsh C19 Evidence Centre, and indeed we were very active at the early stages and throughout of the pandemic in terms of rapid synthesis of evidence to inform pandemic decision making. So we're currently growing the team, and we've recently published a new strategic plan which is available on our website. I won't say much about that other than it's a mercifully short read. It's only 5 pages. So if you want to have a quick dip in, it won't take you long to get a sense of what the key strategic direction is for HCW going forward. But these are our top 5 objectives for this year going into next year. So with our increase in funding, we very much want to expand the topics that come to us, and I'm hoping you can help with that. We want to significantly increase the number of evidence appraisals that we produce and the guidance that we offer for care services. We're specifically targeting social and digital care innovations for appraisal in 2022. We're continuing our work to support time-critical COVID-19 and policy decision making in that front. And obviously we're piloting and rolling out our technology adoption audit function in the next 6 to 8 months. And again, much more detail on these things within the strategic plan if you've got time to have a quick look. So I just wanted to finish off by thinking a little bit about how HCW can support AHPs and health scientists and what's the reciprocity in this relationship. So hopefully some of the themes are obvious. So we have a real cadre of experts in terms of rapid evidence appraisals. We can look at safety issues, clinical and cost effectiveness issues, and we also have a lot of expertise in patient and public involvement. The clear output obviously is the evidence reviews and the guidance that has a national adopt or justify status. We have a lot of expertise in specific methodological areas, including a really expert group of health economists that can build de novo economic models if that's something that you need to support technologies that you're bringing forward. And we also offer, as I mentioned, a very specific scientific advice service to support innovators and developers to bring their technologies to market to expedite their benefits as soon as possible. And on top of that, we have a regular training offer, all of which is free, with introductions to both health technology assessment methods and health economics. We appreciate that the volume of work out there is much more than HCW could ever address, and so we see an important part of our role is trying to, I guess, improve literacy and allow people to take on some of the appraisal aspects that they can do themselves within their own local settings. So thinking now about how can AHPs and health scientists support HCW? Well, identification of priority topics for appraisal would be, I think, probably the most important thing, and it'd be really helpful if we could discuss how HCW can target your audiences to identify the topics that will bring forward the most value for services. We're always looking for experts to participate in our rapid review processes to really make sure that the evidence we're synthesising, which is often international and not Welsh specific, is appropriately contextualised to care pathways and services within Wales to inform the guidance preparation. And of course, it's really important for us to try to get our guidance and our evidence reviews disseminated as widely as possible. So any help that you can give us with that and in the conduct of the audits over the few years to come, that would be very, very helpful indeed. So like Annette, I just wanted to finish off by posing some challenges that we could perhaps return to within our discussions now. So there are 10 here, but I'll just very quickly. So how can we bring forward the technologies that are priority to AHPs and health scientists? Do you have any technologies that you can suggest for divestment opportunities? Often we've got to divest from things to invest in new things, but we often find that people are quite reluctant to give things up, so we don't get many disinvestment topics. So if you've got any, we'd be really interested to hear about those. Which are the networks within your constituent group should we target to raise the profile of HCW and get those topics in? What do you think are the kind of 5 top 5 technologies that are likely to affect your services in the foreseeable future? What are the ones that are keeping you up at night and thinking about, gosh, how will we assess them and implement them and roll them out? Have any technologies emerged of interest during the C19 pandemic? Do you know of any social care technologies? Many of you work within health and social care settings, so are there any that you think you can bring forward there? The same with digital technologies, and Annette has outlined a raft of new digital technologies, and the pace of that is really picking up. So that's the reason for the digital call next year. And do you have any innovations that are in development that you would welcome HW support on, scientific advice or health economic support, whatever it may be, to help you develop your evidence-based case to support adoption across Wales? And how can we raise the profile of that offer? And then finally, obviously we've got lots of methodological expertise, and I've mentioned the training opportunities. I'd be interested to hear if there are any appetite, if there's an appetite for that, and if we can work with you to bring forward that offer for AHPs and health scientists. We'd be very interested to do so. So I'll stop there, and hopefully that will leave us a little bit of time. Thank you very much for your attention. And I think now we've got the opportunity to take some questions and have some discussion. And I think we said at the beginning, you can raise your hand, and Rachel, who's facilitating for us today, will allow you to open the mic and to raise your question. Or alternately, you can put your questions within the chat box, and we can address them that way. Thanks so much. Just take the slides down.
Nobody's raising their hand. There was one question in the chat box, I think.
Yeah.
There was, so if I read that out, it was from Mark, although Mark has now left. He said, were there any technologies that came through in the pandemic that were completely left of field? The only two that I can think of the top of my head was the scratch and sniff, which is essentially a little card that you just scratch off and then you sniff it, and just to make sure that you can still smell, as part of the sort of one of the symptoms tester for COVID. That didn't really take off. There wasn't a huge amount of evidence on how it was used. So then the other one was also to do with smell, and it was to do with the using dogs to try and identify COVID cases as well. So neither of which have really taken off. So those are the two that immediately spring to mind.
Yeah, I think what I'd say in that is there were quite a lot of kind of a random left of field ideas, but a lot of the things that were brought to HDW are registered on the National Horizon Scanning platforms, where companies trying to position existing technologies with a COVID angle, and they often didn't have evidence to support that. So that was definitely challenging because it was huge volume and not often evidence to go with them. We did have a couple that were interesting. We had one that we did a joint scientific advice on with NICE, and that was ResApp DX, but it was pre-regulation, and it's a coughing app. You cough into your phone, and the actual tone of the cough can impart information about how severe your condition is, and they were trying to position that with a COVID-19 angle, and certainly we gave advice on the evidence they would need to bring forward. But yeah, I would say that there were some left of field, and often it was a bit of a free-for-all. Companies didn't always have the evidence to back up the value proposition claims that they were making. So there was lots of discussions about how they might get there and be able to do
John
that better.
John has just asked you a question. It's to do with workforce contribution. It's under the Q&A bit, Susan.
Okay.
Training offered by HTW. Oh, there we go.
Okay. So much scope to improve. Can you expand some more about training offered? Yeah, certainly. So at the moment, we offer an introduction to health technology assessment. We previously ran that as a face-to-face workshop, actually using HW guidance and Welsh problems to actually work those through. And we've had about 200 people come on it, had 95% approval ratings. We've transitioned it to a virtual offering because, of course, of the situation we're in just now. And likewise, we ran an introduction to health economics workshop to give people who are new to health economics some general literacy around about health economics and its application and how it could be used. Again, that's gone to a virtual offering, and we're now just working on 2 follow-ups for that. that. So one is going to be a much more in-depth look at how to critically appraise medical literature from a health technology assessment perspective, and the second is going to be looking at specific techniques of economic evaluation. So there are a range of ones and what ones are appropriate in which situations. Some are much more simple than others, and when to use which ones and when to ask for help. We're also going to be making those offers with the new intensive learning academies and trying to put forward those as opportunities for professionals out there. If MD has an interest or they have a group of colleagues that would welcome that, we'd be very happy to discuss that with you. And I think the other thing that people have found really useful is, I think, attending and observing either an HCW assessment group meeting where we review the evidence, or the actual in-public meeting of the appraisal panel where the evidence is critiqued and the guidance is formulated. I think people really feel once they've been to a meeting, they kind of get it, they understand what is the offer and what it can bring to the table. So we'd be delighted to hear of any suggestions or requests for training, and we certainly would be happy to work with people to help as far as we possibly can.
I would certainly echo that. Even though I'm a healthcare scientist with 40 years experience, I really learned it's only when I got involved with NICE and it was on one of the on the committees that I learned such an enormous amount. So it is really worth actually being involved, and then you really learn about all sorts of sort of health economics and how the assessments are. It is an art.
Yeah, and
Science and art.
yeah, a mix of science and art.
Yeah.
Yeah.
There was there another question from from Mark? There was another one. Are there any technologies approaches that are likely to be routinely used going forward that you would not have predicted? The main ones that have gone forward, certainly for point of care, have been ones that we had prior to the pandemic, such as the isothermal technology, the lamp technology, the PCR, but really they were in big labs, big machines. What's actually happened is they've all miniaturized. Even the film technology that the thin film technology that I showed, it was there, but not really being used prior to the pandemic. So that technology was there behind the scenes, but it has really come to fruition during the last 18 months.
Yeah, I think for me it's just been the rapid escalation in the adoption of digital. Really, the things that have happened so quickly that I think otherwise might have taken years to sort of get in and embed themselves in the system. I get what is it they say, necessity is the mother of invention, and so I think people have just adapted and taken whole new approaches to working. I guess the challenge is still trying to understand, though, that in those different approaches to working, do they deliver the same outcomes for users and for patients? And I think that's really important. So even where there's an evidence case for adoption, I think Annette's point about then that post-market surveillance, trying to understand the ongoing use of the technologies, how the evidence matures and develops, I think is equally important that we keep our eye on that as well as things go forward. And important to say that HCW doesn't always say yes, sometimes we say no, but we do revisit our guidance and we update it if we think that the evidence is substantively altered in a way that it might alter the decision making. And indeed, Freestyle Libre and corneal cross-linking are two recent examples where initially for corneal cross-linking we didn't support and the evidence matured, and we're now in a position where we have supported it. And Freestyle, we initially only targeted it in people who were finger prick testing more than 8 times a day, because the cost effectiveness analysis clearly showed it wasn't cost effective otherwise. But I think the evidence has matured and it's now been able to be supported for a much broader adoption for people who are using who are insulin dependent and diabetic. So I think it is important to sort of revisit the evidence as it comes and goes as well.
Yeah, absolutely. And one of the problems we had, I suppose, early on was the fact that the evidence wasn't there. Because COVID was so new, we didn't have the evidence in the beginning, and we had to try and make decisions on sort of certainly technology and adoption of things where there wasn't a lot of evidence. So that's where the research and evaluations came in, and that's how we in Wales took part of through that, because we in essence created the evidence so that those technologies could be adopted
Yeah, and I think it's a really important point, Annette, because I think the HCW, traditionally we're often looking at the published evidence, but we're moving into that real world evidence space much more quickly, and we've become much more permissive in what we consider as evidence. We'll look at audit data, we'll look at registry data, we'll look at local evaluation data. Effectively, we'll assess the best available evidence, and that always isn't necessarily published. And I think it's important for people to know that, because I think they often assume that we'll only look at published peer-reviewed. We'll basically refuse nothing except blows and consider things in the round to give technologies a fair chance with the best available evidence that they have at that particular time.
I think that if there aren't any other questions, I think that concludes our session. I think we have spoken for 59 minutes and 46 seconds.
Gosh. Well, thank you for the questions, and do get in touch if there's anything that we can assist with. We'd be really delighted to help, and do bring forward some topics from AHP and health science, please. We'd love to get them.
Yeah, thank you.
Thank you.